Good morning, everyone. I'd like to thank the organizing committee and especially Sebastian for the invitation. I'm going to talk about the painful hip arthroplasty and the ion release. In its prosthesis, we have particles and ions, especially cobalt and chrome, which are released from the implants as they abrade against one another. And those ions, they go to the surrounding tissues. So the body's normal defense mechanism becomes activated, and a cascade of events are leading to inflammation of the immediate surrounding tissues and implant failure. That's the mechanism. Of course, we have very rarely manifestations may occur in various organ systems. So what's the outcome of this tribocorrosion? In fact, increased wear and corrosion leads to implant failure and stem taper fracture or metal corrosion, and you have seen many of those pictures during your practice. And what is the clinical implication? That's adverse local tissue reaction, the alveoli, hypersensitivity, inflammatory reaction, metallosis, local tissue necrosis, pseudotumor, renal function impairment, chromosomal damages, maybe some cases with cancer, and placenta-crossing ions. And what's the clinical scenarios? Those are the clinical scenarios I'm going to go quickly through. What about the screws? The screws have been blamed about osteolysis, so in case you can avoid screws, that's the best. But today we have the high cross-link poly, and already Seb mentioned, and the osteolysis minimized, but in case you can avoid the screws, it is better to do that. What about the monoblock and the modular dual mobility? There is a lot of confusion, but if you see the literature, almost 30% of the dual mobility hip had metal ions level more than 1 microgram per liter at 1 year post-operative. And then if you go to the monoblock, about 20% iron detection. In the modular dual mobility caps, 39 detection of chromium more. In the monoblock, it's more the cobalt. So the overall rate ion elevation is 5.2 for chromium, for cobalt, and 1.6 for chromium. The femoral head doesn't seem to have any association about the composition of the femoral head in the elevated iron in the serum. And of course, as we follow up the patients, the ions are decreased. What about metal on metal? Raised blood metal ion levels are featured in all metal on metal bearings, but that doesn't mean necessarily that they have clinical symptoms. And also, there is a lot of discussion about the consensus of the cobalt chromium ion threshold levels at risk. So if you see the MIRA, they recommend 7 microgram per liter, but in US, they talk about 10. What about the hip resurfacing? Again, elevated blood levels of metallic ions, chromium, cobalt, and molybdenum. And so they have increased metal ions up to 8 years post-operatively. Some of the cases you can see, again, with metal on extra large polyethylene, we have, again, ion release and a lot of damages. And pictures like that you see every day in the practice. If you do revision surgery, you see that there is a lot of ions coming to that. What is the bad thing with this? It is that the patients are not very symptomatic, and they come to you in the late days with such pictures. Corrosion at the neck stem junction, again, high stresses on the modular neck, stem neck junction, particularly in cobalt and chrome devices. They lead to corrosion, metal ion release, and pseudotumor formation. So in case you can avoid, you should avoid. Today there is not much in practice on that. Metal on metal modular head, again, you see the, disasters, and today we don't use anymore. What about the SROMs? Any additional metal junction is vulnerable to mechanical failure, so component dissociation and mechanically assisted crevice corrosion. In case you can avoid, again, this. I know that's very popular in the States. In Europe, we prefer maybe the short Wagner stems in such cases. What about the cables and wires? The cable debris facilitates bacterial seeding, and of course, you have higher infection rate. So that may be related to reduced phagocytosis. About 60% of the dull miles cable alloy are made from cobalt. And of course, we know that the cable breakage can increase the osteolysis up to 83%. What about the metal allergy? There is a lot of discussion about metal allergy. Nickel, cobalt, and chromium, known as allergic components, especially the nickel, which is a preferential release from the prosthesis. So the skin changes. It's allergic, such as allergic contact to dermatitis or prototypic delayed type hypersensitivity eczema in the periprosthetic tissue. And other cutaneous reactions is the urticaria, vasculitis, erythema, swelling, and tenderness. So we need to define what is the normal and the toxic metal ion concentration, and there is differentiate between allergy and infection. Sometimes it's confusing. So what's the clinical manifestation of metallosis and ion concentration? It is extreme pain associated with tissue deterioration, pseudotumors, osteolysis, instability, implant loosening, trochanteric pain, noise, the joint movements, bone fracture, and implant failure. Other more serious but rare manifestations, the neuropathy, cardiomyopathy, skin rashes, thyroid problems, and fatigue. What's the diagnosis? You heard a lot about the diagnosis. Ultrasound and MRI can be helpful, very helpful, in order to determine the pseudotumors. The management is revision surgery, but if we have bilateral metal-on-metal implants, we can have increased still. After revision surgery, you can still have increased metal ions, especially in the other side. So some of the clinical findings you see. And today, there are innovations, but still we have problems with these metal implants. And the take-home message is that metal debris are coming not only from the metal-on-metal implants. The metal ions do cross the placenta, and they cause systemic effects, minimize micromotion and metal debris generation. Proper surgical technique, it is important. We shouldn't mix the implants. You need to recognize patients, asymptomatic patients at risk, and then we need to revise. Thank you very much for your attention.